But multiple family groups were offered in this particular trial if conduct difficulties are what got you in the door. It was the presenting issue, the thing that your teacher, your family, your community was concerned about. The majority of families had low household income. The majority of families based on the communities that we work in East Harlem, Central Harlem, and the Bronx were African American or of Latino descent, but again, incredible diversity around family forms, incredible diversity around what Latino means, what African American means. New York is obviously the home of immigrants, and so lots of diversity within this particular sample. The entire protocol was designed and redesigned with researchers, providers, and families in partnership. It targets, those of you that know evidence-based practices for kids with conduct difficulties, it targets the factors in the literature that many of these evidence-based practices are guided by. If you look within the literature, you're real clear that family processes can be the key to help kids behave in an improved way, that lots of the family targets are around parenting skills. I used to think that this was really important and relatively easy to change until I had those pesky 5 children, and now I realize some of the parenting processes that are targets of this intervention are some of the hardest to change around. Jennifer's laughing because she's thinking about her 10-month-old twins right now. But the evidence-based points us if you want a child to get better in terms of their conduct difficulties, you really need to take a look at parenting skills, child management skills, family communication, relationship qualities within the families, positive parent-child interaction, incredibly important in the evidence base. What is not so clear from the clinical trials around kids with conduct difficulties is who actually were in those trials, who did well and who dropped out. So as you dig around through the methods section, which I torture my MSW students now at NYU, that we have to look at actually those numbers in the middle of the method sections, what you see is a pretty consistent pattern, which is families under high levels of duress, stress, families vulnerable to poverty, families with single parents at the head. Those are families that are much more likely to drop out of the trials or do poorly. That was about 100% of the kids and families that we work with in our clinical settings and in our trials. And so we had to pay attention both to what the evidence base suggested was so important to helping kids with conduct difficulties do better behaviorally, but we also had to attend to what we thought were some factors that really led families to drop out earlier, to not do well. That was an incredibly important piece of another part of the evidence base that we had to bring in as we were designing our multiple family group strategy. As we started to put together the protocol, then to guide the multiple family group sessions, which are parents and kids coming together in over a relatively brief number of weeks, only 16 weeks, 4 months of service. But in the context of 2/3 of kids and families not getting service, and also in our state, the modal number of visits to child mental health is 1, followed by 2. We thought 16 weeks was a whole lot of service, and it actually mapped onto the evidence base that suggested that you needed a couple of months with families to start to see an improvement in their conduct difficulties. So as we worked on this protocol collaboratively with providers in practice and families with practice, we started to put together a set of intervention units, many of whom, if you design interventions, you put together sessions, what's the focus, what are the activities. But we also realized from providers, this is a mouthful on this slide. This one's only a partial list of the evidence base. Hard to remember, hard to really, not that useful for providers to kind of keep track of. And even more importantly, the families on our collaborative group said, I think, white people are interesting, they'd say. Child management skills, you say. Does that mean being a good mom? And the thing you talk about within family support or positive parent-child interaction, does that mean getting along with each other? Enjoy each other's company? And so in some ways, for families, this language was interesting, seen as actually devoid of family life, and as I reflected on raising my own children, I had to agree. So in fact, that very hard collaborative working group broke down the evidence into 6 words. that providers potentially could remember in terms of the evidence-based targets for multiple family group, and words that resonated with families about important parts of family life that they could really think about as important to how kids do well. So that's where the 4 R's and 2 S's come from. This is a very hardworking, I think, brilliant group. Summarize the evidence base in four words that begin with R and 2 words that begin with S. And these became the empirically informed targets for our multiple family group intervention. Rules, roles and responsibility, respectful communication and relationships, as well as stress and social support. And all of this work, there's some, thanks to Dr. Thayer and other journals, there's existing papers that I can point you to so that you get more information. And also these protocols are available through our Center for Technical Assistance in New York State. So I'm happy to point you to where these materials are. What's also very important as a collaborative working group of parents and providers and funders and ourselves worked on this intervention protocol, the strategic decision was made that clinicians and parent advocates would co-facilitate these groups. In New York State, family support workers are becoming more and more a significant part of the workforce. I know that's not true in every state, although as I look at Affordable Care Act and our Medicaid redesign efforts, it does look like more and more we're going to have the opportunities to be working with parent advocates at our side. And so in the interest of time, I'm going to breeze through a little bit of the methods so I can get to what happens with kids with complex difficulties, except to say that as we designed our intervention protocol and redesigned it, we had to be sure that there was enough flexibility that we can incorporate a very wide range of family need and child needs, but still pay attention to the 4 R's and 2 S's. We had to be sure that there was enough opportunity for families' cultural values, their perspective on parents and kids' relationships, highly influenced by a whole host of variables that relate to how long you've been in the country, what's your cultural value, what your mother told you to do. That there had to be enough flexibility so that this could work across a large number of families. And so we designed the intervention protocol with both making sure that you paid attention to the evidence base, but also that providers and families have the ability to work with the material and make it seem real for them. This is the conceptual model. We think that the 4 R's and 2 S's lead to better engagement, better relevance. We think those 4 R's and 2 S's through actually coming for care potentially impact your parenting skills and family communication within family support. And we think that influence your conduct difficulties. But we also think that incredibly important attention needs to be paid to parenting stress, coping, emotional supports, and stigma. So the aims, as all of you write your aims, are to test the impact short-term and long-term on a whole variety of child and family measures. And so we're at the tail end of a randomized effectiveness trial set within 10 outpatient clinics in New York City. Kids are 7 to 10, low-income African-American Latino families participated, again presenting behavioral difficulties of youth as a primary entry criteria. Here's what the design looks like, thanks to very talented doctoral students like LaToya and others. About 400 families randomized to multiple family group or standard of care within these particular clinics. Each one of these clinics becomes a separate implementation site with lots of challenges that I won't go into right now, but the other presenters were articulate about what those really were. To date, we have emerging findings from the first 408 youth and their families involved in the study. And I'm going to first present the main effects, but thanks to Bruce Thayer and others, some of the main effects are published. I'm going to get to kids with complex issues right after that. I'm going to present 4 data points, baseline, mid-test, post-test, and 6-month follow-up. Here's who was in the study, just a snapshot. Adult female caregivers led the way in terms of families. This is not to say there are not fathers and father figures around. Many of them participated in these groups as well. About a third of the parents were born outside the U.S. Half the parents had completed high school. You'll see equal breakdown of African American Latino families. Average age of the children in the study were 9.5 years. This is the first set of kind of outcomes that we were very interested in, and this was attendance. Multiple family groups of 4 R's and 2 S's intervention sessions were offered over a total of 16 weeks, I told you before. And what we were incredibly pleased about, if I had one of those little pointers, I'd be running over and pointing at 16 weeks, we had about 80% of families picking up their graduation certificate from multiple family group. We were really pleased. To be humble, these bars, I didn't even make the bar go up to 100%. We had both attendance and non-attendance within multiple family group. However, in comparison to our randomized services as usual, only about 15% of families were there 3 months later in terms of services as usual. This isn't just, we're not the only research team to find this. You know this from your agency settings, that their engagement is the first hurdle that evidence-based practices have to overcome. And we know for many of the first generation of intervention developers, engagement was assumed. There were lots of incentives, bells and whistles, so you actually could come. But then when you start to implement in the services kind of research way, when those bells and whistles are started to withdraw, very difficult in terms of engagement. So we felt like with this kind of data, we were on the right track. What happens in terms of outcomes? I apologize for this horrific list, but I apologize more for the family participants in our study. The burden that they have to go through to fill out standardized measures, they were unbelievable. I'm going to concentrate on just a couple, the outcome measures that have parents reporting on their child's difficulties, as well as parent stress and parenting practices. So the data I'm going to present to you is just looking at the 2 groups over time using random coefficient modeling, thanks to Sue Marcus, who does just a terrific job with our field data. The data in this particular table suggests that we're getting strong effects from 8 weeks to post-test, which is 16 weeks to 6 months follow-up, in terms of childhood disruptive behavior, impairment, overall severity, social skills, parenting stress. To make it just a little easier for you to see, to make it a little bit easier for you to see, there's a nice graph. It's very nice, and it shows you that kids' ODD is going down. She's got the magic touch. Suggesting that kids' disruptive behavioral difficulties are going down for our experimental group, and staying pretty much the same for our comparison group. You'll also see parenting stress indexes. There's a set of families that really parenting stress was not the biggest issue. There were other issues, and so those parents that started out with clinically impressive and significant parenting stress, those are the ones that we kept track of most importantly. And so I just want to get to, before she shows me the 5-minute mark, within this particular study, and I'm happy to refer you to the main outcome papers, within this particular study, what happened to the high-need families? What do we know about families that were headed by parents with their own mental health needs, for example? What do we know about families that were under high degrees of stress, high levels of stress? And so we started then for this particular conference, thank you for having us look at our own data, to really start to look at families with low stress, families with moderate levels of stress, and families that were highly stressed in terms of their circumstances. And I really want to give our Dr. student Gerald Jackson, he really worked hard on this data for his dissertation and for others. Also, my colleague Geetha Gopalan, she was very interested in how about families with child welfare involvement. Were they in this particular sample? In fact, 83 families reported a history of child welfare involvement. And so as we started to look at subgroups of what we called high-need families in this data set, we started to look at, first of all, were they demographically different from the larger sample, from each other? And in fact, we didn't find too many of those demographic differences. What did we find? This is work from Geetha Gopalan that suggests that child welfare status did not influence whether families attended or not, did not make a difference in terms of their average length of stay. That's an important finding because in the literature it suggests that families in child welfare, families with a history of child abuse and neglect, families with a report history, they're more difficult to involve in kids' mental health. And so we thought that that was an important finding, unexpected, but important. The second is Gerald looked at data around stress of caregivers. At the bivariate level, those families that experience low stress, mid-stress, and high stress, those lengths of stay, the mean average 10.4 for low-stress caregivers, 9.6 number of sessions for mid-stress caregivers, and 8.3 for high, although there is some difference, at the bivariate level, not statistically significant. At the multivariate level, they do make some difference in terms of risk of dropout. But what was important is that it looked like for multiple family group, at least you could stay long enough that the literature suggested we might be able to help your child. So they promised to be on time to get us on time, so I'm going to end with a couple of words. This is a very humble story. It's one that has a study that has both main effects that we're very happy about. We seem to be able to help children and their families with conduct difficulties with those 4 R's and 2 S's, with them meeting with their parents and other families. There is some beginning evidence that we can hang on in this model to families with more complex needs, with families with high levels of stress, potentially child welfare involvement. But there's a lot that we have to learn. There's a lot that we have to learn, and so we're trying to build on this work and really think about how do we really rely on the evidence that exists, but really work with providers and families to make sure that the implementation challenges are overcome and that these can become very engaging services. So I'm going to start with what the definition of what the Institute of Medicine considered a really good practice. And that's defined as an evidence-based practice that integrates the best researched evidence and clinical expertise with patient values. And I think that it is in that combination that potentially we can rely on what exists in terms of evidence, but also bolster its impact and the likelihood that it's going to be engaging for kids and families. Collaboration, I think, is important. And with that, I just want to acknowledge so many of our partners. This is not work that you do by yourself, and so I really do appreciate the time, attention, and hardly anybody is sleeping. So with that, I'm going to turn it over to my discussant. Thank you.